Welcome all faculties, delegates and PG students for this unique session to update and revise our knowledge regarding cardiopulmonary resuscitation. This has become now our tradition to celebrate IAP CPR Day to recognize the tremendous work done by our great teacher, late Dr. Anand Shandilya sir. It was my privilege to do two BLS PALS workshops under him one was in Pune and Hyderabad. To update the CPR in various age groups, we have today national faculties, namely Dr. Narendra Nanevdekar sir from Kolhapur, Dr. Santanu Deb from Shillong, Meghalaya, Dr. Sanjay Bapna sir from Pune, and Dr. Abhay Bang from Nagpur. So I welcome all of you once again. Today we have my friend who is a pediatric intensivist from Nasik, Dr. Amol Murkute, to moderate this very important session. Now I request him to proceed. Over to you, Dr. Amol.
Thank you, sir. Good evening to one and all. सर्वप्रथम आमचे सर्वांचे गुरु आणि आदर्श डॉक्टर आनंद शांडिल्य यांच्या स्मृतीला मी वंदन करतो. I am really honored to be part of this excellent and much needed event organized by MAHA-AP. And for that, I thank President Dr. Ramakant Patil sir and Secretary Dr. Amol Pawar sir for giving me this opportunity. Actually, in front of these stalwarts of IAP, BLS and ALS, like Dr. Nanivdekar sir, Dr. Santanu sir, Dr. Bafna sir, Dr. Akash Bang sir, I am really too minuscule to moderate this session, but I'll try my best. It is only the love and respect for the Dr. Anand Shandilya that keeps us all moving and motivating. And all of us will agree that there is not a single activity across the length and breadth of India which is run today, and there is no activity without the mention of Dr. Anand. Last few years, actually last couple of years, this National Week, CPR Week and Day celebration has gained a tremendous momentum. Actually, yesterday, for example, in Nasik, we conducted a mass awareness program at a bus stand where all drivers and conductors were given the opportunity to learn the BLS. And I am sure that the day is not very far where all the patients, be it a man, woman, child or infant with sudden cardiac arrest, will get a privilege of getting the BLS sequence on himself or herself and to increase his or her chances of survival. And I hope in the coming year, with increasing awareness among the commoners, we will get more people to come forward and practice this BLS sequence during any untoward incidents which will happen around us. Rather than clicking photos and shooting videos during that incidents, we want more and more people to come forward and practice BLS sequence. So without wasting much time, I request Dr. Narendra Nanivdekar sir to start the session, and his first session is on the significance and importance of this National CPR Day and Week. Over to you, sir. Thank you. Dr. Narendra Nanivdekar is actually past national convener of ILS BLS. He was also executive board member for Central IAP 22-23, and he has been a huge pillar and support for all instructors like us in the field of ALS BLS. Thank you, sir. Over to you, sir.
Yeah, thank you, Amol, for this kind introduction. And I'll start sharing my screen. Actually, I'm going to talk much more on the, just a moment. Mine is more of a general talk. Why this? What is the significance of this National CPR Day and Week? And in due course, I will come to Anand because you have heard from Pallavi as well as from Amol, and of course from both the Amols. From Amol Murkute as well as Pawar about Dr. Anand Shandilya. So we'll come to it. So what is the significance of this National CPR Day and Week? First of all, the need, whether there is a need, yes. In an emergency, identifying an arrest situation and prompt CPR will definitely help the victim. But this needs some knowledge about BLS and of course, presence of mind, and not last but not the least, a willingness to help. If these things are in place, then anyone can help the victim who is collapsed at any place. And if this is done correctly, one may save a life, a victim who is known or unknown to you. And we are already knowing that awareness in general public is very poor, leave alone this knowledge. So with this aim, we decided that we need to celebrate this. So now it is our responsibility to make people aware about the knowledge of CPR. So the aim is the entire aim of this day as well as week is to sensitize the pediatricians, the healthcare professionals, and of course the lay people about the awareness of CPR and how it can save a life. And with IAP, ALS, BLS instructor pool of more than 500 and IAP CPR centers of more than 50, the infrastructure is already in place. And idea is to utilize these resources and try to reach the maximum people. Now, why CPR Day? Each one of us will be able to contribute in one way or the other. You need not be a BLS instructor to spread this message. And all the national days are already being there, having an established protocol. So last year we have tried to regularize. Last year we have made a launch of this, although the CPR day was celebrated 2 years prior to that also. So it's a new baby, but it has already started thriving well with whatever reports we are getting in from all over India this week. This has been a very, the enthusiasm is very much there amongst all the ALS instructors as well as the IAPNs. The aim for this is each one can save a life. Now this each one includes not only the BLS providers, it is also a lay person who can save a life. Now why 21st July? Now we come to Dr. Anand Chandelier. There may be many who are there in this audience who may not have heard or seen him. I would recommend you go to YouTube and type Dr. Anand Chandelier and see his lectures, his orations, and you'll understand what kind of person that he was. Yesterday, 21st July was his birth anniversary. And for us, BLS and ALS group, he was the most sought after facilitator for all the ALS and BLS courses. And of course, for the rest, he was an excellent orator and a well-read person in both pediatric as well as non-academic. And of course, his involvement in various modules made him known all over India. He was an astute clinician, teacher par excellence, and a thorough gentleman to the core. And he was an instructor in 1998, being chosen by none other than Dr. Natesan Janaki Raman, the giant who brought PALS course to India, now labeled as IAP ALS course. He became national convener in 2007 and continued to contribute to ALS courses. And most important, he was instrumental in negotiating with American Heart Association during a rough time over copyright issues which happened with IAP. So unfortunate that we lost him on 1st January of 2019. The day we always think should never have come to our lives. And at an ALS BLS fraternity felt the loss and felt that his contribution was always needed. So executive board decided that CPR Day will be done in his memory on 21st July, that is Anand's birth anniversary. Now, why ALS BLS group? We have already got people in fray. We have got the infrastructure in ready. The BLS course was separated from the ALS in 2010. In 2013 action plan, there was a grand mass awareness programs which were done, including one at Kolkata Airport, Dum Dum. And these media advocacy showed us that we can go to multiple people to save life. And this was supported ably by our president in 2019. So the group has multiple milestones. I'll not go into details of each one of them. But what is important is that we have got this e-Sanjeevani course, which any one of you can do. And we have got the IAP CPR handbook, which is in progress because BLS is a copyrighted term. So we'll be using more of a CPR as a main term. So these were the objectives. And since 2019, in 2019, there were a few activities conducted. 2020, COVID was at its peak. So no major activities. 21, we did an IAP ALS webinar. So using how to approach a COVID patient during using an ALS approach. And 2022 nationwide activities were done by all the enthusiastic IAPNs. Now it has gone a big way. It is already, the process has already started, and now it is already done in an autopilot mode. I am sure in future this will be done in a larger scale with more and more branches, and be ready for some surprise announcement which will be done tomorrow at the national webinar by none other than our president. So with this, I thank you all, and I'll ask Dr. Akash Bang, Dr. Sanjay Bafna, and Dr. Santanu to share their academics. Thank you.
Thank you very much, sir. I am sure all of you will agree that there could not have been better person to start this wonderful session and to tell us all about Dr. Anand Shandilya. And I think only Amitabh Bachchan can talk about Dilip Kumar. So Nani sir, we love you all. Thank you, sir. Now I request Dr. Akash Bang, who is a consultant pediatrician at AIMS Nagpur, who is also the state convener for IAP ALS for the state of Maharashtra. And he'll be talking mainly upon CPR in adults as well as children. Over to you, Akash sir.
Thank you. Can you see my slides?
Yes, yes.
Yes, sir.
Yes, sir.
So first of all, at the outset, let me thank the organizers, Maharashtra IIP, and the moderator for making this happen and inviting me for this very important session. And I must say that if you think what is the most basic function or task of a doctor, if you ask that question to yourself, you will realize that it is basically the most basic task of a doctor is saving lives, right? And saving lives, saving an arrested life is one step ahead. If you save even one life in your lifetime, I'm not talking about patients. Patients we all keep on doing day in and day out. But in real life situation, in bus, in train, in flights, if you save even in your house, in your corridors, even if you save one life, that would suddenly make you realize what is the importance of CPR, what is the kick, and what is the joy that it gives to you. The converse is also true. If someone is dying in front of our eyes, and if we are not able to help, if we are not able to effectively do CPR, and if you are not able to help that life, there is nothing more shameful than that. So let us have a look at why CPR is important. If I ask you a question, how long can we live without food? Probably the answer would be in days. How long without water? Probably hours. How long can we live without oxygen? So what is your idea about this? So the thing is that without oxygen, our brain won't be able to live without more than 3 to 5 minutes of life. So within 3 to 5 minutes, brain starts to suffer from hypoxic damage. And who delivers oxygen to tissues? We all know that it is the blood, which is pumped by heart, which delivers oxygen to tissues. So in the arrested situations, many times we would, instead of running around, if there is an effective CPR, an effective chest compression, probably that would go a long way in delivering oxygen to tissues and to brain. So what is basically CPR or BLS? BLS is a sequence of steps to perform CPR. As Dr. Nani Vadekar already commented, this is a patented word. So we keep on referring to CPR as a synonymous of BLS. And who needs CPR? So any victim of sudden cardiac arrest would require CPR. Cardiac arrest may occur in a variety of situations, in and out of hospital. In adults, it is often due to cardiac causes, including rhythm abnormalities like ventricular fibrillation or pulseless ventricular tachycardia. But in children, as all of you IIP members would agree with me, The major cause of cardiac arrest is due to respiratory failure and or shock. So we know. So when our juniors tell us, all of you will agree with this. Our juniors tell us, sir, शाम तक सही था, रात को suddenly बच्चा deteriorate हो गया, suddenly arrest में गया. So there is nothing like sudden arrest. If you give some situations of rhythm disturbances, in children there is nothing like sudden arrest. Most often it is an unrecognized respiratory distress, an unrecognized compensated shock that that degenerates and leads to cardiac arrest. So cardiac arrest is, as we know, is not heart attack. And a victim of cardiac arrest has the best chance of recovery if the CPR is administered by the person standing next to the victim immediately on recognition of the condition. So please remember, let us understand that the fact that we discussed in the beginning, that brain, within 3 to 5 minutes, brain would start suffering the hypoxic damage. And if you think of a arrest situation, 3 to 5 minutes, to how it will pass, you will never know. So we need to understand BLS, we need to understand CPR. More than that, all of us, we need to teach all our subordinates, all our nursing staff, all our juniors, even attendants, everyone in the hospital must be able to perform CPR, because you never know when a person goes into cardiac arrest. 90% of those, it has been studied that 90% of those who experience cardiac arrest die because of not receiving timely intervention. So this is something, just imagine 90% of the mortality because of cardiac arrest can be prevented if all of us spread the message of BLS. So how to recognize cardiac arrest? Definition is a person who is unconscious and unresponsive, who is not breathing, and who does not have a pulse. In a child, you can modify this a bit. So a child is labeled as being in cardiac arrest if there is cessation of circulation due to absent or ineffective mechanical cardiac activity, which will be manifested as no pulse, and clinically the child will be unresponsive and not breathing. So for all practical purposes, an unresponsive child who is not breathing, you may not spend more than 5 to 10 seconds in looking for pulse. If a child is unresponsive, not breathing, we take that it is pulseless. So let us have a look at what are the steps of CPR in adult. Now, first and most important part, as you would agree with me, someone is lying down there, someone is arrested, you try to help, you go to help that patient, and you also lie down beside that patient because there is something which has sent you into cardiac arrest. Let's say a person is suffered electrocution because there is a puddle, there is a water puddle, there is an electric wire, there is an electric current in that water puddle. Because of that, someone got electrocuted and is lying down there. You go to help that person and you also lie down because you also get electrocuted. We don't want that situation. So first and most important is verifying the scene safety and checking for responsiveness of the patient. So assess whether the scene is safe so that you yourself don't become the victim. Look for any evidence of etiology. That is, we call this circumstantial evidence. Like for example, कोई वहाँ पे पड़ा हुआ है and beside that person you find a bottle, an open bottle of antidepressants. So you know कुछ तो गड़बड़ है, हो सकता है antidepressant खाया होगा. There is a child who is lying down and you find that there are peanuts, शेंगदाने पड़े हुए हैं वहाँ पे. So we know that child might have choked and that might have led to arrest. So look for some circumstantial evidence and then assess the victim for a response. So how do we assess for response? So this is scene safety. You can have a flood situation, a fire situation. These are the drugs or electric situation. These are the situations where you don't want to be another victim. So verify the scene safety. Your own safety is a priority. So once you have assessed the safety of the scene, first and foremost is checking for responsiveness. So how do you check for responsiveness? Because someone might be sleeping, you never know. So we need to check that that person is really unresponsive. So firmly tap the victim on shoulder and ask a question loudly in a language that he would be likely to understand. So we usually ask, "Kai zala? Are you okay? Kai zala?" Something like that. Do you need some help? Something like that you can ask. So this is what is the assessment of responsiveness. As soon as you find out that the person is unresponsive, you should activate the emergency response system and get AED. Now, this may vary according to the situation. If you are in hospital, this may just mean calling some nurse to activate emergency response system. If you are in an outside hospital situation, this may just mean calling an ambulance. So the meaning of this sentence would change according to the situation and to the according to the context. So activate the emergency system and get AED. So if you are the only person, you would send someone to get AED. So ask someone to get AED or defibrillator and emergency equipment. Then quickly look for breathing and do a pulse check. So look for normal breathing. And so we are talking of an adult patient, and check for carotid pulse simultaneously. This should not, you should not waste more than 10 seconds in this. Remember, every passing minute will increase the mortality by 17%. So every passing minute is important. Every second is important. So we should not waste too much time in breathing and pulse check. Quickly do a pulse check. And as soon as you find, so what further action you should take will depend on permutation and combination of breathing and pulse. Okay. So this next action will be determined by this. So let us say a situation where breathing is also normal and pulse is also present. Obviously, this person does not require rescue breathing. This person does not require chest compressions. What this person, so isme kya hai? Breathing bhi hai, pulse bhi hai. So what is the problem? This person is unresponsive. So all that this person needs is careful monitoring. So monitor the victim till help arrives or victim is taken to hospital. Till that time, keep in recovery position. What is recovery position? We'll see in the next slide. Now suppose pulse is present, but breathing is not there. Now this, because pulse is present, there is no need of chest compression in an adult. All this adult requires is breathing, rescue breathing. So provide rescue breathing at the rate of around 12 to 20 breaths per minute. So which means one breath every 3 to 5 seconds. But if there is no breathing and no pulse, this person requires CPR. So immediately we need to start CPR, starting with compression. Please remember the sequence of ABC has now been converted into CAB. So remember to take a cab and start high quality CPR. This is the position we were discussing. This is the recovery position. So what is happening is, just see one leg is folded here. Ek pair fold kiya hai. This is to support the position. One upper arm is folded. This is to prevent rolling over. And the other arm is behind the chin. So you can Google this. You can take a snapshot of this and you can see this type of recovery position is taught to everyone. Now we see a situation where pulse is not there and breathing is not there. We must start high quality CPR. We will see what is high quality CPR. We need to position at the victim's side, place the victim on a flat, firm surface, kneel down on your knees beside the victim. I'll show a brief video at the end of this. So don't worry. All this will be, you will get a visual impression of what all is being taught. Place the heel of your dominant hand over the lower half of the sternum of the victim. Place your other hand on the first hand, grasping the fingers of the first hand by the second hand. Straighten your arms and position your shoulders directly over your hands. And start giving compressions and breaths at the rate of 30:2. While doing the high quality CPR, the important characteristics are push hard, push fast. Hard means up to 5 to 6 centimeters. And in children, up to 1/3 of the AP diameter. Fast means around 100 to 120 per minute. Deliver compression in a smooth fashion. Allow complete chest recoil. Minimize interruptions. Count while delivering. And when your compression quota is over, don't waste more than 10 seconds to give rescue breaths. So give 2 rescue breaths by opening the airway and giving 2 breaths. Now, whenever the person, remember that when you saw the unresponsive person, you had shouted for help, you had called someone for getting AED. Now, whenever that person comes with AED, whenever AED is available, you should use it as soon as possible, because if it is a shockable rhythm, then defibrillation is the most important thing. So if prompted, the AED is like an automatic machine. It will itself tell you that I am now analyzing rhythm, stay back. Okay, this is shockable rhythm. No, go ahead and give a shock, stay back. So all these things, the machine will tell you. As soon as the shock is delivered, start CPR again. So this is very important, that whenever you deliver shock through AED, you should not again waste time in analyzing rhythm. Immediately start high quality CPR. So AED looks like this. and it is very user friendly. So it will have numbers like this. So there will be one number at the on off button, then 2 number will guide you, and then 3 number will tell you that this is the time to give shock. When it is the time to give rescue breaths, you must remember to open airway first. So open airway by head tilt and chin lift, and then give 2 breaths. So if I have time, I can show 2 rescuer BLS CPR. This is a 5 minutes video. So organizers, do I have time?
Yes, sir. Please.
So is this visible? Is this visible?
Yes, Akash.
BLS sequence for 1 rescuer. Now we shall take a look at complete BLS sequence for 2 rescuer. In 2 rescuer CPR, a specific role is allotted for each rescuer. Rescuer 1 should be beside the victim, and rescuer 2 should be positioned at the victim's head end. The rescuer 1 role would be to perform chest compressions, counting out loud, and giving chest compressions in the right technique.
1, 2, 3, 4.
The rescuer 2 role would be to maintain an open airway and give breaths with bag and mask, and should simultaneously watch for adequate chest rise, avoiding excessive ventilation.
1 and 2.
Rescuer 2 would also encourage rescuer 1 to perform chest compressions which are fast, deep, and allowing complete chest recoil between the compressions.
1, 2, 3, 4.
You're doing a good job.
7, 8,
Push
9,
hard,
10,
push fast.
11, 12, 13,
Press down
14,
at least
15,
5
16,
centimeters,
17, 18,
but not
19,
more than
20,
6
21,
centimeters.
22, 23, 24,
Allow
25,
complete
26,
chest recoil.
27, 28, 29, 30.
Providing high quality chest compressions requires a lot of energy and results in exhaustion. So, in a 2-person rescue scenario, rescuer should switch roles after every 2 minutes. When you are using an AED, after attaching the chest leads, the machine analyzes the rhythm over few seconds, and this is the time when you can switch roles.
AED is analyzing rhythm. Let's switch positions.
Stay clear of patient.
If AED is not available, one can switch roles after every 5 cycles of CPR. So let's review some key important points. First rescuer positioned by the side of the victim should perform chest compressions and should count out loud and clear. The second rescuer positioned at the head end should maintain an open airway and give 2 breaths after every 30 compressions. Rescuer 2 should also monitor chest compressions and make sure that rescuer 1 is performing correct chest compressions. Making sure that rescuer 1 is pushing fast, hard, and allowing complete chest recoil without any interruptions. If the chest compressions are inadequate, then rescuer 2 should suggest corrections to rescuer 1 accordingly. Compression rate for 2 rescuer CPR is 100 to 120 per minute. The compression to ventilation ratio for adults is 30:2 even for 2 rescuer CPR. Compressions should be paused when giving ventilations. However, if an advanced airway is in place, for example an ET tube, then there is no need of pause. When performing CPR with an AED, one should switch roles every time the AED tells you to reanalyze the rhythm. When performing CPR without an AED, one should switch roles after every 5 cycles to prevent fatigue. The switch time should take less than 5 seconds to minimize the hands-off time.
Coming through. Scene is safe. Hey, are you listening to me? He's not responding. There's no circumstantial evidence of drug abuse or poisoning. Somebody activate the emergency response system and get an AED. He's not breathing. There's no pulse. Start CPR. 1, 2, 3, 4, 5,
I'm
6,
here to
7,
assist you.
8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
AED is analyzing rhythm. Let's switch positions.
Stay clear of patient. Deliver shock now.
Stay back.
Shock delivered.
Shock delivered. Resume CPR.
1, 2, 3, 4,
You're
5.
doing.
So there is one more video which I want to show. So there are some common mistakes people do while doing chest compression. So this is a very short video, just 1 minute video. We'll just show this.
Yourself by the side of the victim. Remove any clothing so that the bare chest is clearly visible. Put the heel of one hand at the center of bare chest over the lower half of the breastbone. Then put the heel of other hand on the top of the first. Make sure your shoulder is exactly above your hands and your elbows must be straight and long. Push hard and fast. Avoid pressing directly over the sternum as it can lead to serious injury. Make sure that the chest recoils completely back after each compression. The time for chest compressions and chest recoil should be approximately equal. While doing so, your arms should be kept straight and elbows locked. If you bend your elbows, you will fatigue your arm muscles more quickly. Compressions should be regular and smooth, giving same time for compression as well as relaxation. Be sure the heel of the hand is in contact with the chest wall at all times. Compress and release in a steady rhythm. Be sure to keep your fingers off the chest. Massaging or pressing on the chest with the fingers in contact with the chest wall may cause rib injury. One more error is rocking chair technique, where compressions are done from side instead of straight down. Bouncing compressions are not very effective and can also cause internal organ injuries. If you keep your hands crossed, it will make it more difficult to apply the right pressure. If you do not bring your shoulders above the hands and stay in the sitting position, the chest compressions will remain ineffective. As an adult CPR, sometimes you don't push hard enough during child CPR because you don't want to hurt the child. However, it's better to push too hard than not hard enough. Injury is better than death. Hence, you should position
Okay, so we have seen common mistakes in chest compression, and we will now quickly go ahead and look at the child CPR. Now we have understood the basic concepts of CPR. I will just show what are the differences in child CPR from adult. So we, in emergency situations, in CPR situations, we don't have time to look at the actual age. So we define children as from age of 1 year to puberty. Puberty defined as chest or underarm hair in males, or any breast development in females. What are the key differences? Remember that in the first slide we said that younger the age, more is the likelihood of cardiac arrest being the result of shock or respiratory distress rather than cardiac problem, primary cardiac problem. So when to activate emergency response system? If the arrest is not witnessed and you are alone, it is always recommended to provide 2 minutes of CPR before leaving the child to activate ERS and getting AED. Now, the only exception here is when the arrest is sudden and witnessed by you and you are alone. So let's say on a football field, if a 6-year-old child collapses in front of you, or let's say if you are in a boarding line of a flight and in front of you in the boarding line, suddenly a child collapses, This is the situation where you have witnessed the collapse. That is the time when before starting CPR, you must activate ERS and you must get AED and then return to the child. Because here shock could be a priority. Pulse check is done either in carotids or femorals depending on the size of the child. That is another difference. Third difference is that we said that in adult, whether it is single or two rescuer CPR, we would always go ahead with 30:2. In child, if there are two rescuers, we would use the ratio of 15:2 compression is to ventilation. Compression technique, because the child size will be slightly smaller than adult, so you can use whether either one hand or two hand. If the child is too big, let's say an adolescent, you can use two hands. If the child is small, you can use single hand compression. Compression depth, instead of 5 centimeters, now we say at least 1/3 of the AP diameter of the chest. Common mistakes we have already seen. So do not do a rocking CPR. Don't be a bouncer. Don't be a bender. Don't be a double crosser, massager, or just a sitter. So these are the common mistakes which we must avoid. Now I request Dr. Shantanu and Dr. Narendra to start with infant CPR. Sorry, Dr. Sanjay and Dr. Narendra.
Thank you, Dr.
Thank
Akash. It was clearly a very lucid presentation and you simplified it to the core for the better understanding of the audience. And as you already told, the CPR in adults and children, the main takeaway is to do not only CPR, but to do high quality CPR, because we all instructors believe in giving high quality CPR. And the components of high quality CPR you have already enlightened us. Now I request Dr. Sanjay Bafna to enlighten all of us with respect to CPR in infants. And unlike adult, and there are few key differences with respect to CPR in infants as well. Dr. Sanjay Bafna is a senior consultant pediatrician in Pune, Jahangir Hospital, as well as in Bharati Hospital, Bharati Vidyapit and Medical College, Pune. He has been a senior IAP, ALS, BLS instructor since long time, and we have learned a lot under him. We have done many courses together. Over to you, Dr. Sanjay Bafna.
Hello. Thanks, Amol. Thank you, Team IAP, Maharashtra Maha IAP, for giving me this opportunity. I think this is a very, very important day for all of us, the PALS instructors, and also an emotional day for us. So this is a very good initiative by Maha IAP. I think last year also we had a lot of programs in Pune IAP, and I think we carry on with this program every year. So without wasting much time, let's now look at the infant CPR. There are some key differences. Akash has beautifully told us about the adult and the child CPR. One thing I think which we must remember is in child CPR, for two rescuer, the video actually I think was incomplete for the lack of time probably. But for children, for two rescuer, it is 15:2. The ratio is 15:2. For adults, it is always 30:2. So when you have a one rescuer CPR, it is universal ratio of 30:2. For a child or infant CPR, when you have two rescuer, the ratio becomes 15:2. That is your 15 compressions with two breaths. And apart from that, there are few key differences as how do we give breaths and how do we give compressions in infants. I think once we see the video, it will be very clear, and then we can have few comments from myself and Dr. Narendra. So I would request Nani to just show us the video for assessment first, so that I think it will be clear for all of us how do we do assessment. We'll have the video first, and then we can discuss the key elements.
For the
Nani, you can
purpose
start.
of BLS sequence, the term infant means less than 1 year of age, excluding newly born babies in the delivery room.
In this clip, we will show you the CPR sequence for an infant, both by one and by two rescuers.
Coming through. The scene is safe. Baby, she's unresponsive. Somebody please activate the emergency response and get an AED. She's not breathing. There is no pulse. Starting CPR. 1, 2, 3, 4.
Since you have already seen the CPR sequence of an adult, it would be easy for you to understand the CPR sequence of an infant, which has many similarities with a few changes. Assess for scene safety.
The scene is safe.
Assess the victim for a response,
She's unresponsive.
and if there is no response, shout loudly for a nearby help,
Somebody please activate the emergency response and get an AED.
or send someone to get an AED or defibrillator and emergency equipment. Look for normal breathing and brachial pulse simultaneously to determine the next appropriate action. Breathing and pulse check should not take more than 10 seconds. In adults, the pulse is checked in the neck for carotid pulsation. However, because of short neck in infants, feeling for carotid pulse is difficult. Pulse check in infants is done by feeling for the brachial pulse by placing 2 or 3 fingers on the inside of the upper arm between the elbow and the shoulder. Press the index and middle finger on the inside of the upper arm to feel for the pulse. Remember, the whole procedure should take at least 5 seconds and not more than 10 seconds. Next action will depend on victim's situation. If breathing is normal and pulse is present, monitor victim till emergency help arrives or the victim is taken to hospital. If no normal breathing but pulse is present, provide rescue breathing. If no normal breathing and no normal pulse within 10 seconds, begin high quality CPR with cycles of chest compressions and breaths in 30:2 ratio, starting with chest compressions using the CAB sequence. Use 15:2 ratio if 2 rescuers are present. Use AED as soon as it is available. If shockable rhythm, give 1 shock and resume CPR immediately for 2 minutes till prompted by the AED for next rhythm check. Continue cycles till ALS providers take over or the victim becomes responsive.
Nani, can you stop sharing? So I think in this video, the focus was on assessment, and 2 important things I think already has been emphasized by Akash, that first you need to do scene safety. You have to see that the scene is safe, check for unresponsiveness and shout for help. Calling for help is very important. Calling for aid is very important. And then we go on to CPR. And during assessment, the next step is of course pulse check and look for the breathing simultaneously. In infants, instead of carotid pulse, we check the pulse at brachial, which is the midway between your elbow and shoulder. Just roll your finger inside, that is the medial aspect of your forearm. So that was the message from this video. Now we will go ahead and see how do you actually give CPR if the child, say we have seen that the scene is safe, the child is unresponsive, there is no pulse and there is no breathing. We want to start CPR, and this is a child who is less than 1 year and we are alone. So that is 1 rescuer CPR. How do we give it? I think let's first see the video and then we'll discuss. Nani, can we have 1 rescuer CPR for infant video?
Yes, just a moment.
Baby, baby, she's unresponsive. Somebody please activate the emergency response and get an AED. She's not breathing. There is no pulse. Starting CPR. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One, 2, 3, 4.
During the chest compression as a single rescuer to an infant, you will use just 2 fingers of one hand and use the other hand to tilt the head and keep the airway open. The infant should be lying on its back on a firm, flat surface so that the chest compressions will be more effective. Place the tips of 2 fingers in the center of the baby's chest, just below the nipple line. The pressure should be applied just below the imaginary line between the 2 nipples, avoiding the tip of the breastbone. Push hard and push fast to a depth of at least 1/3 of the depth of chest or approximately 1.5 inches. Maintain a compression rate of 100 to 120 per minute. After each compression, release the pressure on the breastbone, allowing the chest to recoil completely. Count out loud as you do sets of 30 compressions.
1, 2, 3, 4, 5, 6, 7.
This is called the 2-finger technique, and it is the perfect technique if you are the lone rescuer.
So in this video, we have understood that there is a difference when it comes to an infant. We are using 2 fingers instead of 1 or 2 hands. And because the infant is small, and here your second hand is on the forehead of the child to stabilize the child, because it's very difficult otherwise to stabilize the child, and child should be lying on a firm surface. Second important, I think, difference was when you give the breath, you should be covering, if it is mouth-to-mouth breathing, you should be covering mouth and nose both in an infant. Whereas in a child, you are just locking the, or you are giving mouth-to-mouth breathing. Here it is mouth and nose both should be covered by your mouth. So that's the key difference. And apart from that, I think we always keep on, emphasizing that it is push hard, push fast, 100 to 120 per minute. There should be adequate chest recoil and no interruption. So this is a high quality CPR, what we call. Nani, anything from your side?
Yeah. Yes, I would just like to add a couple of things. All of us should know that there are 2 important things which Sanjay has talked about. One is the recoil, allow the recoil. Now keep in mind, when we are trying to generate a pulse, when we are trying to give a chest compression, this is to pump the blood from the heart, so that the blood is supplied to all the vital tissues. And this is the recoil during which the heart is allowed to fill. So it is something like an artificial diastole, because unless in the diastole, the heart is filled properly, in the compression phase, the heart will not be able to pump out more blood. If all of us know that in extreme tachycardia, the heart does not fill because the diastole is shortened. So heart does not fill at all. So that's the reason why that elastic recoil or the recoil is very, very important. And you have seen that whenever we give the 2 rescue breaths, we are limiting ourselves to less than 10 seconds, simply because the moment your hand is off the compressions, and that is the time when the circulation is going to be standstill. And once you start giving the chest compressions, first few compressions will not be adequate enough to generate adequate blood supply to the vital organs. So that is the reason why this breath, whenever the breaths are given, we do not waste more than 10 seconds. So in case you are not able to open the airway and give adequate chest rise, you may reposition it once or twice, but later on, see to it that you don't waste more than 10 seconds. I think the rest of the things are well explained by Sanjay. Thank you.
And we go to the 2 rescuer CPR now.
Sure.
Just a 2 minutes video now. For,
yes,
if you have 2 rescuers and if you have an infant, how do you change the position of your hands? How do you give chest compression? Rest of the things are same. Just the technique of giving compressions is different. And I think we'll see that, and then we'll move on to the next session. So here we have 2 rescuers.
Coming through. The scene is safe. Baby, she's unresponsive. Somebody please activate the emergency response and get an AED. She's not breathing. There is no pulse. Starting CPR. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
1,
and 2.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1 and 2.
1, 2, 3.
If no normal breathing and no normal pulse within 10 seconds, begin high quality CPR with cycles of chest compressions and breaths, starting with chest compressions using the CAB sequence.
Nani, we can stop. I
Remember,
think.
there are some important differences while performing.
Okay, fine. So here we have seen that the chest compressions now were given with thumb. And yeah, Sanjay, go ahead.
No, carry on, carry on.
So, and the ratio was changed to 15:2 for the simple reason in pediatric age group and for infants, the respiratory component predominates. And that's the reason why we will give more importance to the breaths also. At the same time, just keep one thing in mind, that the initial sequence always remained the same, where you called for help the moment you understood that there is a unresponsive victim, be it a child, be it an infant. For the simple reason, for an infant, in case you have seen the collapse in front of your eyes, good chances that this could be a cardiac event. And for the others, if the infant is found there and lying, that we do not know whether it's respiratory or otherwise, there you will always give few cycles yourself and then call for help. Of course, if there is a help around, then that somebody else will go and fetch an AED, because all those who have done, all of us have done resuscitation at one point of time or the other, and we know how exhaustive it is. It is both exhaustive in from both the mental as well as the physical point. So this covers the way resuscitation is done. I think we can proceed to the next session. Over to you, Santanu. Over to you, Amol.
Thank you, Sanjay sir. Thank you, Narendra sir, for enlightening us. It is, Sanjay sir, it is always wonderful listening to you.
Thank you.
As far as next session is concerned, the new changes, we have come a long way from sequence of ABC to now the present sequence of CAB. And what are the present changes or the latest changes as far as CPR is concerned? Dr. Santanu Dev from all the way along from Shillong. He is a HOD as Nazareth Hospital, Shillong, Meghalaya. He is also the past zonal coordinator for IIP ALS BLS 21-22. He is at presently editing the IIP standard treatment guidelines. And we are very fortunate to have him today to enlighten us as far as CPR National Day or Week is concerned. So, sir will be talking mainly on the newer changes with respect to CPR. Over to you, sir. Santanu, sir.
I think he is logged off. We'll call him immediately.
Amol sir, shall I tell Sanjay sir to do the next one or shall we wait?
No. I'm calling him immediately. Yes.
Okay.
In Meghalaya too, there must be rains and a lot of electricity walks.
म्हणून मी दोन याच्यावरून जॉईन झाले सर. इकडे सुद्धा लाईट जाते.
He was there, I think he was there. I don't know what happened.
He joining, we'll wait for 1 or 2 minutes.
Okay.
Yeah.
Okay, I think so.
In the meantime, if somebody has got some questions, I think there was some.
Yeah, if there are
which was
any
raised.
questions in the chat.
Yeah.
Wait. Previous chat might have gone.
I'm so sorry, I got locked out.
Yes, sir.
Yeah, carry on, Santanu, please.
So I can share my screen?
Yes,
Yes.
sir. Yes, sir.
Yes, sir.
Is it visible? Am I audible?
Yes, correct. Yes, sir.
Okay. So thank you so much. And my special thanks to Maharashtra IIP for inviting me over. My good friend, Dr. Ramakant Patil and Dr. Amol Pawar. And so wonderfully moderated by Dr. Amol. So my presentation is very short, which means that changes are actually very few. And I'll be concentrating mainly on the changes in basic life support, because the resuscitation guidelines, they keep on changing every 5 years. And these guidelines have come from American Heart Association. So these guidelines were updated in 2020, published in 2021. So we will be seeing what are the new changes which have come. So before I go to the changes, I just wanted, I remembered something when all my previous speakers were speaking, is that when you give CPR, try to give CPR on a firm, flat surface. Because many of you will be giving CPR in your hospitals and nursing homes. And if you give CPR on the patient's bed, a lot of your energy will be lost, and your high quality CPR will no longer remain high quality. So you must use some resuscitation boards which you can put below the torso of the victim, and then you can keep on giving CPR. So that is one important thing to remember, other than what my all learned previous speakers have told you. So the first change in the guideline is in rescue breathing. Rescue breathing is the breaths which are given for infants and children who have a pulse, but they have absent or inadequate respiratory efforts. This is called rescue breathing. And the breaths that we give when there is a pulse present is called rescue breathing. So the new update is that one breath should be given every 2 to 3 seconds, meaning that we end up giving 20 to 30 breaths per minute. Whereas the earlier guideline was something like this, we were giving one breath every 3 to 5 seconds, so which was 12 to 20 breaths per minute until spontaneous breathing resumes. So this is a new update, and this is a thing that we are teaching now to all the participants of the new BLS courses or the new CPR courses. So again, ventilation rate during CPR with an advanced airway. Advanced airway means the child already has a laryngeal mask airway, or the child has a endotracheal tube. So in them, when we give ventilation, during that ventilation, we need not pause CPR to give we need not pause chest compression to give the breaths. So there also the guideline is one breath every 2 to 3 seconds. So this is a new update. And previously we used to recommend giving breaths every 3 to 5 seconds. So what is the rationale for this change? It has been seen that higher ventilation rates during CPR with an advanced airway, at least 30 in infants and 25 in children, has been shown to improve the rates of return of spontaneous circulation and survival in children who have cardiac arrest inside hospital. So there is a lot of evidence and data now to say that this is really beneficial. And for simplicity of training, the respiratory arrest recommendation was standardized for both the situations. So our stand, the IAP ALS group stand, is we should target 20 to 30 breaths per minute in both the situations. So we are going to follow what has been recommended by American Heart Association. Next is use of cuffed endotracheal tubes. Remember BLS, when we teach BLS, we don't teach intubation. But when a child or an adult has a cardiac arrest, that child or adult may require endotracheal intubation. And now it is recommended that you use cuffed endotracheal tubes over our uncuffed endotracheal tube for intubating the infants and children. So when we put the cuffed endotracheal tubes, we should choose the tube size properly, the position, and also we must take care of the cuff inflation pressure, which should be usually below 20 to 25 centimeters of water. Earlier, we were a bit iffy. We were saying that both cuffed and uncuffed can be tubes, uncuffed tubes can be used. In fact, we were giving more weightage to the uncuffed endotracheal tubes. So previously, it is recommended that both cuffed and uncuffed tubes were acceptable for intubating infants and children. And in certain circumstances, for example, with poor lung compliance, high airway resistance, or a large glottic air leak, then only we were recommending a cuffed endotracheal tube. So present recommendation says choose a cuffed endotracheal tube over an uncuffed endotracheal tubes. So the rationale is the safety of the cuffed endotracheal tubes is well supported by evidence in children and demonstrate decreased need for tube changes, reintubation, and risk of aspiration. So much safer to use cuffed endotracheal tubes, but we were always worried about subglottic stenosis. So it has been seen that subglottic stenosis is actually rare when cuffed endotracheal tubes are used in children, and when careful technique is followed, especially for the inflation pressures. If they are kept below 20 to 25 centimeters of water, there is very, very little risk of subglottic stenosis. So our stand also is we are recommending now that choose cuffed endotracheal tubes over the uncuffed tubes, and understanding the issues regarding possible non-availability of small cuffed tubes, effort should be made to make it available at your own workplace. All past teaching has been to recommend uncuffed tubes. So there may be a bit of resistance from the older generation pediatricians also, or one can say that there needs to be a bit of unlearning of the old guidelines, so that cuffed endotracheal tubes can make their entry into our PICUs and our emergency rooms. The fourth guideline is cricoid pressure during intubation. So the current update says that cricoid pressure is not recommended during endotracheal intubation of pediatric patients. Earlier, we were not very sure. There is insufficient evidence to recommend routine application of cricoid pressure during pediatric intubation. So what is the rationale? New studies have shown that routine use of cricoid pressure, they reduce intubation success rates. On the contrary to what we were believing, that they improve intubation success rates, it has been found that they reduce intubation success rates, and also they do not reduce the rate of regurgitation. We were assuming that cricoid pressure would reduce rate of regurgitation. That is also not happening. So it is no longer recommended. And the fifth is use of epinephrine. The current update says that administer the initial dose of epinephrine within 5 minutes from the start of chest compression. There is a lot of weightage given now to the use of epinephrine in cardiac arrest, and the earlier recommendation was it is just reasonable to administer epinephrine in pediatric cardiac arrest, no time limit was set, and the guideline was also not very strong in favor of epinephrine. So in hospital cardiac arrest study in children demonstrated that for every minute delay in administration of epinephrine, there was a significant decrease in return of spontaneous circulation, survival at 24 hours, survival to discharge, and survival with favorable neurological outcomes. So all these things are improved if epinephrine is given on time. And this is our stand. We also recommend to achieve the 5-minute target. However, we emphasize to administer epinephrine as soon as possible after ensuring high quality chest compression, because at all times epinephrine may not be available with us, but to give it as soon as it is available, preferably within 5 minutes. Some other changes, like Dr. Nani has said, that there needs to be a change in nomenclature. BLS is an AHA, American Heart Association copyrighted term, and they might the use of BLS in our posters and our banners, in our training manuals, may put us in a false position later on. So this is to be replaced with CPR and cardiopulmonary resuscitations. These are generic terms and can be used by everyone. And the urgent need of the hour is to generate our own data. American Heart Association recommends that epinephrine should be used. We do not know, or we do not have enough evidence to say whether it really helps or not. And in our country, we can generate a lot of data. So it is important to generate our own data and to come up with our own resuscitation guidelines. And we also need to audit the resuscitation outcome, processes, response at our own places of work. Please keep an audit and see how you are faring in your resuscitation. Maybe these will also add to the data from our country. With this, I'd like to thank all of you, but the biggest thanks in my life goes to Dr. Anand Shandilia, who was not only my teacher, he was my guru, he was my friend, he was my philosopher, he was my guide, he was a family member sort of. And I have learned a lot of things from him, and I have traveled to a lot of places with him, conducted so many courses with him. And we cannot have a better way of remembering him than to propagate CPR and CPR sensitization to the masses and to the public of this country. Thank you, Maharashtra IAP, once again, and thank you so much for a patient hearing. If there are any questions, I will try to answer them, or I can ask my very learned panel to answer those questions if you have any questions for me. Thank you so much.
Thank you very much, Santanu sir. It was a wonderful presentation, and points such as rescue breathing at the rate of 20 to 30 per minute, using cuff tube, avoiding cricoid pressure, and early epinephrine were well taken. Thank you very much, sir.
Thank you, sir.
With this, we move on to our last part of this CPR webinar, and the topic is the way forward. And to deliver this talk, I invite Dr. Sanjay Bafna to enlighten all of us. Over to you, Sanjay.
Thank you, Amol. This is a very, very brief it's not a talk, but I think just a few suggestions, and maybe I would in fact need inputs from, or we all would need inputs from all the stalwarts of Maha IP and Indian Academy of Pediatrics, National IP, how we can improve the this awareness, how we can improve the legacy set by our stalwarts, including Anand, and how we can propagate the science of BLS. As Narendra said, knowledge, of course, awareness is less, but in fact, the awareness about BLS itself is less. So there are few suggestions from my side, but I think it is basically just very extempore suggestions, and I would like to share my screen. So
Go back, Sanjay.
is it seen?
Yeah, very much.
Okay. So I think, as I said, it's just my spontaneous thought process that what we can do and how we can improve this science and create awareness about BLS. So for pediatricians, I think we have BLS and ALS courses for postgraduate students and pediatricians, but unfortunately, most of them are attended by postgraduate students and very few practicing pediatricians attend. So I think for us as a BLS, ALS instructor, I think there may be a need that we conduct courses only focusing or targeting practicing pediatricians, and those can be done at least once a year. We should have BLS courses only for practicing pediatrician, or only for ALS also similarly for practicing pediatricians, because many times there are exams and the senior pediatricians they may not like to attend with the junior or postgraduate students. So that can be one way of propagating this, and there could be even some kind of prizes or something for having a branch who has maximum number of BLS courses or BLS doctors, or we can have a pulse, all the IIP members in that branch, they are pulse positive or BLS positive, something like that can be done. GPs, I think, also are actually a target which can be done with the help of IMA. Other general practitioners are also serving a lot of our community. So again, IMA, IIP initiative from local branches can help to propagate this. Undergraduates and postgraduates, I think it is now becoming mandatory for them to have a BLS certificate, and even ALS in some institutes is mandatory for appearing for exams. So that's a good news. And now there are a lot of UG and PG conferences which are happening. Recently, we had a workshop where there was a UG conference and we did a BLS. I think Uday was the convener, where in BJ Medical College, we did a workshop for UGs, which was a BLS workshop. So these are the ways where we can involve more and more doctors. And at present, I think, unfortunately, it is mainly PG or postgraduate student focus. So where we can, try to improvise this umbrella to more doctors and more pediatricians. That is one way. It's basically for all the office bearers to give it a thought. Secondly, for nurses, I think there is a separate ALS, BLS course for nurses which we conduct. So if the hospitals, we do regular refresher sessions in our hospital for nurses. So we can decide that there is a BLS course on Nurses Day in majority of the hospitals wherever the instructors are working or other trained people are there. There may be something which can be made mandatory for nurses before their certificate is given for their ANM or some other things. IIP BLS course is already running for nurses. We need to pick up more nurse BLS instructors. We have few, but if we are more, then I think, because they would identify and they would be more encouraged to learn from their nurses rather than doctors. They are scared of doctors. So that is one way. And of course, regular refresher. It may not be a full 4 or 5 hours course, maybe just a refresher which we are running right now. Something like that can be done at a regular interval, which we do in our hospitals. But I think that can be one way of propagating this science. So targeted general population, I think teachers, we had a BLS course or BLS session for 2 hours last year for teachers, where almost 100 teachers from all over Pune attended that, and they were very, very happy. And most of them were taught actually to how to give CPR. So that went on for 2.5 hours, and we just showed video and let them practice. Then policemen is another targeted population, ambulance drivers, hospital paramedic staff. Many hospitals for a NABH requirement, they do it for paramedic staff. That's a good news. For clinic staff, actually for our receptionist and for our staff in our clinic or nursing home, I think they should also be taught. And there could be pre-conference session for local public, particularly emergency or intensive conferences. It can be free for them. Maybe I think it doesn't actually need any money. You need mannequin and you need people to teach them. So that can be one way of looking at how we can target general public. For lay public, college students are always interested and enthusiastic. BLS can be conducted in societies, school children. Now BLS can be whenever we as a pediatricians are invited for parent teacher meet or to give a talk on parents get together, we can suggest that we have a session on BLS, maybe half an hour or 1 hour session during their parents get together. That would be a great way of propagating this. Now all of this would need resources. So as Dr. Narendra has said, we have 500 BLS instructors, but I think it's less for the population of 1.3 billion, where BLS is a science which I think needs more propagation. Of course, ALS is a very, very advanced and sophisticated science, but BLS can be taught by even trained nurses, trained people from targeted population also. So can we, as an office bearer of BLS, think of something where we can pick up teachers or policemen or some people who can be given certification and have a small course, and then they can be utilized under our supervision. They will not perform it alone, or they will not conduct courses alone. There will be one person from BLS pool, but there are 2-3 other resource people where we can use them, and then we can have these whatever ideas I have said. It's not easy to just do those execute those ideas with the help of only 500 instructors. I think we need bigger pool. We need a short PPT or videos. Just now we have conducted 1 hour session. So similarly, just BLS for infant, child, and some science, and then just technique, how to do it. So that would attract more public, because people are not having that much time. And the mannequin is the only resource which we need, where local IIP branch and IIP branch can help. I think whenever we do courses, if we can, and many times the local IIP would get some benefit or they would make some profit. And if we can make it mandatory or request that, okay, you made say 20,000 rupees as a profit, you need to buy some mannequin out of that and keep it in the local IIP branch. So that can be used for layman or public, though we don't have to rely on getting mannequin from Bombay to conduct the layman or BLS for teachers. Last year we had one mannequin from our hospital, and then we had 1 or 2 from we borrowed it from other people. So if local IIP has few mannequin, maybe a 1 adult and 1 child, lot of BLS courses for laymen can be done. And then, as I said, more trainers we need, and BLS instructor TOT can be conducted. Like we have a lot of TOTs every year for all these conferences. So that can be one of the resource which can be done. We have double engine in the form of Amol and RD, my CR. So I think they can have some thought process. They have a Mahapedicon coming up. So whether they can create a pool of BLS instructors by getting a TOT performed during Mahapedicon would be one way of looking at it, and getting at least 1 person, 2 people from each district. And so we have, or medical colleges should be targeted, so that every medical college has 1 instructor. So that is something which can be thought of. And media, of course, I think can be utilized. BLS videos in waiting rooms, but they should be short videos, very short videos and very short presentations, so that people or parents, they are attracted. And of course, this is an impact of BLS. Permanent. I think you people have recently must have read that during marathon, I think he did a successful BLS and saved a life. Of course, Uday Rajput, one of our proud BLS instructor who did similar thing on a flight. So I think, as said, even if you save one life during your lifetime by doing a great CPR, I think that gives you a kick, that gives you a great satisfaction, and that's what we want to propagate. But our aim is to not to get CPR done by a trained instructor, but when lay people start doing this, I think that is our aim, and that's what Western people follow, and we need to propagate this science so that we have more and more people and trained people who can perform CPR, because we cannot be everywhere. So I think this is from Nani. Nani has sent me this last time. We've been doing this ALS, BLS for last many years. And as Nani has said, हम अकेले ही चले थे जानिब ये मंजिलें, मगर लोग साथ आते गए और कारवा बनता गया. Thanks Mahavi for this wonderful session. I think this is what we want, and this is how if every state does this every year, maybe every quarter year, then our job will be done. Thank you so much for your patient listening.
Thank you, sir. Very well thought of the presentation and the ideas. Ideas such as conducting BLS courses on Nursing Day, teaching BLS to clinic staff, BLS at parent-teacher meetings, and making all local IB branches to buy mannequins are I think, wonderful points and are easily doable. I thank all the faculties for sensitizing all the attendees towards CPR, and I am sure all of them will get sensitized to attend more and more hands-on workshop which IAP, ALS and BLS body is conducting all across the nation. With this, I hand over to Dr. Amol Pawar,
Dr.
sir.
Santanu has raised his hand. He wants to say something.
Yes, sir.
Yes, sir. Santanu, sir, please.
Yes, sir. Dr. Sanjay, so many nice points you have put out. I just wanted to add that we actually find the eBLS to be very useful for us. That means the BLS provider course needs a lot of planning. Then there is the question of whether the candidate will pass in the end or not. And then procuring books, the cost per candidate is quite high. But we find that good turnover in hospitals amongst junior doctors, doctors from other departments and nurses can happen if they are given the link for eSanjeevani or the eBLS and they come to your institute for 2 hours to learn hands-on. We find that very useful. That can be one way where we can cover more people, sir.
Fantastic. Yeah, I
Just
know.
my
I
thoughts,
know.
sir.
That's
Yes,
important thought. And I think whether we can have some poster, that link, which can be put in our reception for parents, because awareness is what is required. So I think pediatrician's office is a great place for advertisement and awareness, creating awareness. So if we next year, if we can have a poster with the link and people may be interested in learning, we can put that.
Even we can, Amol, we will hand over the link to Amol. We can distribute it amongst all the pediatricians in Maharashtra so that they can go through that eBLS videos. So it's an easier task to be done, as rightly said by Santanu. And we should be making a utilization of this. In fact, Dr. Lokesh Tiwari has put in a lot of efforts to prepare those videos, and we have been still using them. Of course, the changes we keep on adding. So that is what is important. You learn through the videos and you try to actually perform it. And as rightly has been said, we are also in thinking of putting those videos, albeit short, on the or hospital videos where non-specific channels are kept running. In case we are able to run these educational videos, first of all, that will make people aware. So tomorrow, if somebody sees you through the peeped window that you are resuscitating a child and you are giving chest compressions, I always remember Anand at the end of the day too, when we used to talk about coping with death. Who bolta tha, chhati daba daba ke mara. That's what people will say, but there you have to explain the parents what is done for the resuscitation. And in case more and more people are aware that this is the way resuscitation is done, then that would be a great message to everyone. Once the awareness is there, then people won't feel bad that chest compressions were given to save a life. That misunderstanding would definitely go. And I think even if these messages reach across all the target population and the audience right now, I think our job is done. Thank you. Thank you, Amol, for all of us, for inviting all of us in the first
Yes.
place.
Thank you. So friends, after learning minute details about CPR, you all as a medico may face similar condition anytime, and you should be ready for it to save the life of precious one. And I'm sure after seeing these educational videos and getting all the necessary practical inputs from all these stalwart faculties from IAP-ALS, you are in a position to save the life of in such case. A single precious life saved with your efforts in your practice or in public places will be a real tribute to great Dr. Anand Chandile sir. If someone needs revision of these topics, then you can watch on MahaIP YouTube channel anytime. From Team MahaIP, I thank Nani sir, Bafna sir, Santanu sir, and Abhay sir for enlightening all the delegates and PG students about CPR. Then I also thank my dear friend Dr. Amol, who moderated this session so well with his store of great appropriate words. And with all these young guns like Dr. Amol and others in IAP-ALS team, I'm sure the incoming pediatricians and PG students will have many learning experiences in the form of IAP-ALS courses, BLS courses, then NRP and PALS workshops also. I thank all the delegates and PG students for the patient hearing. I also thank I also thank Pallu ma'am, who is a backup support team of MahaIP, for her coordination. Thank you one and all. Thank you.
Thank you so much. Thank you.
Thanks, Amol. Thanks.
Thank you, sir.
Thank
Bye.
you
Thanks,
all so
Amol.
much.
Both Amol, thanks.